And I'll keep the introductions brief. The next speaker is Professor Witvrouw. Eric started to work at Aspetar in 2013. He's a professor of physiotherapy, PhD in 1998 at the University of Leuven in Belgium. He held 2 master's degrees and has published more than 100 papers in peer-reviewed journals. Eric is a true expert in the field of physiotherapy and rehabilitation. It's a privilege to have Eric speaking on the rehabilitation of post-ACL reconstructions and the challenges of those. Thank you, Eric.
Thank you so much. So the topic of my talk is actually what are the challenges in ACL rehabilitation. Of course, the biggest challenge is, as you can read here, and that is with every athlete. So the biggest challenge is to bring your athlete to his previous level of sports participation without complications and with a safe return to sports on the short and the long term. Now the question is, of course, is this realistic? And what are the challenges? And that is what my topic will be about. Now, when we look in the literature about the outcome of ACL injuries, we say that it's fairly good. And we say that because, as you see here, this is the pre-op line of an international score, of the KOOS score. And when we see what the post-op score is after 2, 3, or 5 years, we see there is a significant increase in the outcome. So this is good. However, when we look at what the outcome of the same score is in a population who has no history of knee injuries, and we put that line over there, we still see that we have a significant way to go. Now, this is only a part of the story. The true story is that this is the mean, the average result in our ACL patients. And it's somewhere in the middle between preoperative values and a normal population. The true story is that the range from our results after postoperative rehabilitation is all the way in between here. So despite we give the same program to all our athletes, some of the athletes end up nearly normal or normal, and some of the athletes end up close to the preoperative values. And that is the variation in treatment. And we don't know, or we don't know that well, how this variation is explained. So I will try to go through my talk to explain why we have this variation, what the challenges are, and how we can deal with that. So which factors actually determine the outcome after ACL rehabilitation? And the first factor, which is a very important factor, is the presence of secondary articular injuries preoperative. In other words, if you have a patient with these injuries, the outcome is for sure not that good as somebody without these injuries. Now you will say, well, what is the message of this? The patient has it or has it not, so I cannot change it anymore. So why do you tell me this? Well, I tell you because we know in Aspetar, and we have some experience with that these players need extra monitoring. Because we know that these patients are high risk of a poor outcome. And we also identified that if we monitor them very, very closely, more close than the others, and we test them more regular, that the outcome, even of these patients, is significantly improved. So that's why I tell you, you have to identify these patients which you know from the beginning that they will do not so good. Second thing is the preoperative assessment. When you do a preoperative assessment, so just before the patient goes to the operation room, that measure is a very good measure of the post-op outcome many years later. So it is an important thing. So we have to try to get our patients as good as possible to the operation room. How can we do that? Well, very important is adding a preoperative rehabilitation program, which we call Prehabilitation today. Prehabilitation has been shown, and you see here the different papers in the last years. Prehabilitation has been shown to improve significantly the results as well preoperative, but also postoperatively. So today it is not a luxury or a choice anymore to do preoperative rehabilitation, yes or no. If you want good results, if you take really good care of your patient, it is an absolute must-have. So pre-rehabilitation is very important, and of course this rehabilitation program is consisted of strength, flexibility, proprioception, etc. Next thing we will talk about, which is very important in the outcome of a patient and in the variation of treatment, is what Professor Martens has told us this morning about proprioception. We know, and he also identified this, muscle reaction times is one of the few variables which is significantly related to a feeling of a good subjective stability. In the past, 10, 20 years ago, we have been looking for which variables determine the subjective stability of the patient. We thought it was postoperative stability, it was laxity, we thought it was strength, we thought it was flexibility. And we did not find any of these variables as important parameters to the postoperative subjective feeling of the patient. One of the only variables, and we know this for a long time, you can see it, it's worked from the early 90s, one of the only variables is muscle reaction time, which is trained and treated by proprioceptive exercises. So the question is, of course, can we change these muscle reaction times? Because as you have heard, many times these reaction times are too slow, they are reactive, so they are at the reflex level. Can we change that? Well, the answer is yes, we can. And we know that perturbation training, that is actually a kind of a proprioceptive training, and you all are aware of this kind of proprioception training. This perturbation training, if we implement it in our treatment program, we have much better results in final outcome. So this is a very important issue. This is one issue you should not forget, and this is one of the issues which will determine that your patients are at the top of the outcome and not at the bottom. Another important challenge and variable which is imperative for a good outcome is quadriceps strength. So it is imperative to have good quadriceps strength, which means if you have good quadriceps strength, or if you don't have good quadriceps strength, you will not have a good outcome. However, if you have a good quadriceps, it doesn't mean you will have a good outcome, but you might have it. So, and we know how we train it. We have to train it during our rehab in a combination with open and closed kinetic chain exercises. We know this for many years, and this is a recommendation of an IOC consensus paper we published in 2018, where we can say we start with closed kinetic chain exercises, but later on we add open kinetic chain exercises. One of the last thing I will tell you during the rehabilitation as a risk factor for a poor outcome is the presence of anterior knee pain. This is the presence of anterior knee pain prior to ACL injuries, but also the presence of anterior knee pain during rehabilitation of anterior knee pain. Now, why do we get anterior knee pain? Well, in many cases, anterior knee pain, and this is a combination of patellofemoral pain with patellar tendon pain, and sometimes it's more patellar tendon, sometimes it's more patellofemoral, and many times it's a combined situation, and I will try to explain why we think it is a combined situation. This anterior knee pain is a frequent finding and is negatively correlated with the outcome, but it's only the tip of the iceberg of overload. So when you train the patients, and we all know that quadriceps strength is so important, so we train them, but of course maybe we overload them. We only know that they're overloaded when they have symptoms, but then of course it's too late, and we have to decrease the training load, and of course the time to return to sport is later. So how can we prevent it? How can we see the iceberg before we see the tip of the iceberg, which are the symptoms? Well, we might have a new tool, and this is what we are using in Aspetar today, and this comes from research in the literature, and we might have a tool, and these guys have shown that the tool is able to look at tendon overload while it does not have, or while it doesn't produce symptoms yet, but while it already or why we are already seeing changes in the tendon fiber classification. And this is something we are using here. And as you can see, we have 4 kinds of fibers. I'm not going to go into detail. And of course, green is good, blue is a little bit changing, red is bad, as you can see here, and you have a distribution of the amount of tendon fibers. The crucial thing here to remember, the red fibers are the ones causing pain, and we don't think we can still change them. But the blue fibers are the fibers going from green to blue and later on to red. But when they are blue, we think, or we have seen, that this is overuse before giving symptoms. And if at that point we can decrease the load, we get these fibers back to normal again, and then we go on. So we try to monitor our patients very closely. This means very frequent testing and seeing where our patients are, almost a tailor-made rehabilitation concept in order to avoid overload, but of course in order to also get good quadricep strength, because we know this is important. This was all about looking at the challenges during rehab. Now once the rehab is over, do we also have challenges? Yes, I think we do have challenges. When we look at ACL re-injuries, we see that we have between 6 and 34% of re-injuries, with an average of 21. Now, when are these ACL re-injuries happening? And this is research we done in Aspetar, so these are data from our own patients. And you see here, this is in days, and these are the amount of the percentage, cumulative percentage of re-injuries, and you see a lot of re-injuries until this point. So actually, you can say that within 200 days, we have a lot of injuries, and at 100 days, we have 50% of the injuries. So this is the take-home message for you. If you see re-injuries, we see them very fast. Almost all of them are happening within 200 days. Now the question is, of course, why is this? Is this because we send them too soon to the rehab? We discharge them too soon? Or maybe our discharge criteria are not good enough? So we did a research on that here in Aspetar, and this is what we did. We followed up 158 patients, ACL patients, and we looked for re-injuries, and we looked at the validity of our test battery. Now, I will show you in a minute, so this is our patient population. Important to show you is that almost all of these athletes return to their previous level. This is the discharge test battery we used, and you can find it on the web. It's not so important at the moment. The most important thing is that I hope you also have this problem, but we have this problem frequently. So some of our patients are close to ending our rehab program, and we test them. Some of them are successful in our return to play test battery, and then we can discharge them. Some of them don't succeed in the return to play test battery, but anyway, they go back to sports. We don't like it, but for this study, it was actually a good thing. Because then we could see whether these guys who met our criteria and went back to sport, whether these guys had less re-injuries compared to the other guys who also went back to sports but did not meet our criteria. And this way we could identify whether or not our test battery was maybe good. So this is actually what we did, and these are the patients, as I told you, 158. So we found, luckily, 116, the majority were fully discharged and went back to play, and 42 did not. Now, what are the re-injuries? And this is the interesting thing. When we looked at the re-injuries in the ones who were fully discharged, our percentage was only 10%, much lower as we see in the literature, especially if we take into concern that all these guys went back to professional level 1 sports. While these guys who did not meet the discharge criteria but went back to sport, 1 on 3 of them, 1 on 3, every ACL patient you operate, in 3 of them, 1 get a re-rupture when they go back to sport too soon. So this is a very, very important take-home message, and this is one of the challenges we are facing, but we can maybe partly predict. So our test battery is a good tool for a safe return to sport in short term within 200 days, within the range where we see ACL re-injuries. Now, what about return to play and long-term consequences? What about the incidence of knee OA in ACL patients? Well, we all know that knee OA seems to be a comorbidity of ACL injuries, whether or not we operate. And this is a nice systematic review, and it tells you actually, here you see knee OA, maybe you don't see it that well, but anyway, you see here, it doesn't really matter whether these guys are operated or not operated, they will always get a very, very high chance of developing knee OA. Now, why is this? And we did some studies about that. So it's a study we performed some years ago. And the question was, are we pushing our patients too hard? Do we send them back to sports too early? Because we measure the ACL strength, we measure quadricep strength, we measure everything, but do we measure cartilage? No, it's not important, cartilage. Oh, it's not important. But all of these patients have knee OA. So we don't measure cartilage while we send them back to sports, and we know that this is a very high risk for them in the end. So this is what we actually did. So we measured the cartilage of our ACL patients at the moment they return to play, and that was the average of 6 months. So what did we do? We did some quantitative morphology, so we measured the 3D volume and thickness of the cartilage. We measured biochemical composition, so the quality of the cartilage with a T2 star mapping. And we also measured the function of the cartilage. And how did we measure that? We put them in an MRI machine. We measured T2 star. Then we let them run for half an hour. And then we put them in the machine again. And we measured the in vivo deformational behavior of the cartilage. And what are the results of this study? We found no difference between a healthy control group and ACL patients at 6 months recovery in the 3D volume. So there was no difference in volume of the cartilage. When we looked at the biochemical composition, we saw that it was significantly decreased. So the quality of the cartilage is not ready yet after 6 months. And when we looked at the function, then we saw that a half-hour run is significantly impacting the cartilage level, and it takes much more time before the cartilage comes back to normal levels. In other words, even a half-hour run has a significant impact on the deformation of our cartilage in the ACL patients, but we send them to the pitch and we tell them, go and do sports, go and play football and whatever, but of course their cartilage is not ready for this. So the conclusions of our study is that this cartilage, at the moment at 6 months, when we send the ACL patients back to sports, is very fragile. It is not ready to go back to sports, and we may think this is one of the many reasons why these patients develop potential knee OA in a later life. So wrapping it all up, what are the challenges of ACL rehabilitation during the rehabilitation? First of all, you have to identify your patients with secondary injuries. You cannot change it anymore, but if you monitor them very closely, your results will get better. But they will never be at the top of your results. You have to implement prehabilitation. This is very important if you want good outcomes. So if you care about your patients, this is not a choice anymore. This is something you have to do. Perturbation training, proprioceptive training is imperative. It is absolutely needed. Strength is also absolutely needed, but you have to monitor the patients very closely, because if you create overload, you have anterior knee pain, and this delays the process, but also affects the 2 to 5 year follow-up results. So it's very important that you don't create anterior knee pain. And you can do this by close monitoring, frequent testing, and a tailor-made approach. What about the challenges of ACL rehabilitation after they went back to sport? Well, only discharge patients after successful test battery. And and you can find it on the web, which test battery we use. These are no secrets. This is shared with all the community. We have a test battery. This is maybe not the best test battery. In the future, we will evaluate whether we can make it better and better and better. But we have shown, and together with us friends in Norway also, they have the same results. If you send these guys to the pitch when they are not successful in a test battery, their chances for re-injuries is much higher. And the last thing I want to point out, 6 months is probably too soon to send your athletes back to the field. Especially the cartilage, it is not ready. In a very recent paper, which is not published yet, but will be published very soon, we know that the re-injury rates, not ACL, but other re-injury rates, is much higher if they are back to sports less than 9 months after the operation, while compared to more than 9 months. Thank you very much.